This film is about how health and social care partners and the public are working together in Tower Hamlets to achieve more integrated care for vulnerable adults, with a particular focus on achieving significant change for September of this year. The ambition for integrated care was set out by the CCG Board Lead for Older People, Dr. Nicola Hadrup, in a first stakeholder meeting in April.
Integration across primary and community care. There's also integration across the secondary care services, hospital services, mental health and social care. Our ambition is to aim across all of those, integration in the future across all of those services, but recognising that actually that's quite a big ask in the short term, and that this is a longer term plan really over a kind of 3 to 5 year cycle. And that in the shorter term, that looking very much towards integration on the health side and bringing in mental health and social care as much as possible.
The meeting on April the 18th identified a number of critical areas for further work and development. These areas included the approach to needs assessment, care planning and care coordination, and the desired relationship between primary care professionals and those in community health services. The meeting considered how services might be organised in and out of hours, and finally how information on patient needs, care plans and progress could be accessed across the system. These issues were then taken back into the separate statutory organisations for reflection and for idea generation at the end of April and the beginning of May. Those attending the early April 18th meeting then reconvened on May 23rd to consider the reflections. The process included learning from the approaches taken elsewhere in London, particularly in Wandsworth and in North West London. Dr. Marion Allwright from Harrow provided an insight into the benefits that patients have derived from intensive care planning and case conferencing through multidisciplinary groups.
The patients get an opportunity to discuss their care as a whole, not just their medical care but the social aspects, the psychological aspects, and also what the carers feel they need, what's working and what's not working. And we then have an opportunity to discuss with consultants to get things done quite quickly, and the patients are almost fast-tracked in certain areas.
With the benefit of the pre-meeting and the experience elsewhere, the room went back to the detail and worked in small groups around the patient experience, the approach to the identification of patients, the approach to rapid assessment and care, care coordination, the development of charters for primary care and CHS, and finally back to the issue of information sharing. The first group looked at the quality of care from the patient perspective. Just how might this be assessed?
We know that it went, how do we know? How can we measure quality in this whole thing? And we came up with this list, so we might ask the patient, do you feel you were understood, in control, involved, had enough time, feel more positive as a result, that this was a good experience? Even if you're really ill, this was a good experience. All your whole care needs were recognised. You know what's going to happen next. Do you know what's going to happen next? Did you have enough information? Do you know who to go to and how to contact them? Did you feel you were treated as a person rather than a condition? And your carers' views and needs were understood. And did you have a sense that the people responsible for your care are working together and thinking together about my care?
A group looking at risk stratification discussed which patients might most benefit in the first instance from a new approach.
From the work McKinsey's did, that we're talking around 16,000 is the figure, I think, locally, with additional 1,800 that are already known in terms of very high intensity users. But we sort of said that was done from data where the single criteria was that they'd had an admission in the previous 12 months to hospital. And then we got discussing, well, is that the sort of group that we want this service to be available to? Are we going to have the maximum effect just from looking at that group? And is it about people that are known to multiple organisations? Is it people that are on multiple registers in primary care? What is it that makes up the risk in terms of risk stratifying? We then got to, well, what does the evidence base say? Beth was clear saying that the evidence base sort of comes up with a number of models and options, but the work that's been done at Nottingham University is pretty much leading you to that you can risk stratify really from the GP database. If a practice has got fairly good QOF data, that actually running a model through that data will provide you with the risk stratification from a health point of view. And we then sort of thought, well, that would be a good place to start, but then we wanted to clearly sort of see how we would be able to align how if that is the group, how do they link through to social care? Are these known or receiving services? And social care discussion was about there is a big difference for them, for the client group that are known to them, are the client group that are receiving services from them. I suspect it's similar for mental health.
A group looked at rapid response and how that might work.
We then started working through, well, how do we respond? What is it we respond to? What is the criteria that you respond to, and how would things physically happen? And we've had quite broad conversations around that, but I think what we are going to have to do is set up a small working group to actually hone that down and actually come up with the goods around what that is going to look like and what it is we're going to do and how we're going to manage it and actually deliver it.
Want somebody to be able to make a phone call and for you to know that somebody will be coming with a rapid response to provide the services that you are needing to hopefully keep you out of hospital. So we kind of got a feel for what we were wanting to get and how that might feel for a patient. And then obviously it will be thinking through, so using a task force to work through some of the actual practicalities of how that might work and how that might actually be set up. And I think we felt very much that actually once you got a bit more clarity about how that rapid response was working, then the assessment might follow from that slightly because you're helping with the assessment. We'll be thinking kind of how that feeds into what's going into the rapid response. So I think we started at one end, but actually I think it will lead back. So it may be two workforces, but it will be, kind of they will lead on from each other, I think. And it's kind of getting the handover right as well, which will be part of with the making sure the assessment is clear, so that the kind of the handover each way will be clear.
A group looked at the relationship between primary care and community health services and how the development of charters might inspire and enshrine a new dialogue and way of operating.
The formation of the actual document and the actual process of making the document was the most important process in actually getting an appeal that actually got to shared values, shared aims and shared goals. So once, for example, our colleagues had actually formed the charter, they didn't have to refer back to it because everyone had input. Therefore, it was a bottom-up formation rather than a top-down imposition. That resulted in increased sense of responsibility and an understanding of roles, but also an understanding of the different pressures in each of those different services. And that's what allowed them to work better together as a team, and that was the benefit of the charter.
A group recognised the need to get down to basics on care coordination.
There were some fundamentals that we're saying need to be there if we're going to get care coordination right, which is at the very beginning get consent, get agencies to agree to share information. It needs to be 24/7. Some of the things we've repeated before, how do we share data? How do we get the responses in place so that care coordination is appropriate? And actually, if it's working well, and I know we've said this before, it's the relationship of care coordination with rapid response and supported discharge, because there will be this cohort of people that we're working with where if we get that right, it might mean you may not require rapid response because you've got a plan in place. But maybe that's an aspiration. I think we certainly talked about single point of contact. Try and direct people to one place. So we were thinking if there is a kind of hub, do you build things around the hub? Is care coordination built around that hub? So that you aim for one contact, but there's a range of people who can then be contacted from there. Similar to the kind of palliative care model I think that was talked about. And I suppose the other thing is let's look at examples that already exist where there is a kind of multidisciplinary approach, whether that be palliative care, whether that be in mental health services. There are things we could probably build on that we've learned that maybe work well and maybe don't work so well. But fundamentally, it is about, you know, we need to build from the bottom about what we're expecting these staff to do. And until we get that right, I think, you know, we'll kind of struggle. So there's still more discussion, I think, about getting the fundamentals right.
And finally, a group looked at the key issue of information exchange.
Started off by agreeing that there are kind of three big chunks of stuff that need to happen. The first chunk is to get people using their primary record electronically, properly. And we've got a full spectrum from GP practices where there are virtually no paper records to people dependent still on paper records in other sectors. And we've also got some real opportunities of lots of our local GPs will have been real pioneers in using IT in general practice. So we've got to, you know, we can use some of that experience to share the kind of people who feel intimidated by IT, people who feel that, you know, not so comfortable making their clinical records electronically. We've got an opportunity to use some of that experience to help get over some of those barriers, but actually establishing for everybody a primary record that is electronic is really essential.
Julie Dublin is the Programme Manager for Integrated Care in Tower Hamlets, and she summarised the next steps of the process.
For September need to implement a lot of the things that you've heard spoken about today. And so out of all of these discussions, we'll be drawing up some programme plans to essentially take forward some of the bits that we need to start delivering on from the 1st of September. These are things that we've already indicated as far as our business is concerned that we're going to hopefully deliver on. So Orion, implementation of the integrated community health teams, and some of the other bits and pieces of work. That's exactly what we're going to be looking forward to. So that's our next step.